Okay, part 2. Now let's talk about, I don't know if I'm going to do this like in 2 parts, or I'll do hepatitis in 1 part and cirrhosis and cancer. I'll probably do that. I'll probably do hepatitis just this one. Okay. Sorry, I should have had that first, but super thirsty. Okay. So let me tell you about hepatitis. There are 5 A, B, C, D, and E kinds of hepatitis that are viral. These are all viruses. And occasionally you can have non-viral hepatitis. So it's a little more rare, but you got to know that it's out there. So here's the thing with the hepatitises. A and E go together. They're very, very similar. B and C go together. They're very similar. D will only occur in the presence of B. So that's important. The next thing, A and E are viruses that are transmitted fecal-oral. So it's a virus that is found in feces, and somehow it gets on somebody's hands and they get it into their mouth and they ingest it. It is common in developing countries, common in, I don't say common, but it's easier to get in developing countries, third world countries, places where a lot of people touch the same thing and then eat the same thing, like college dorms. So let's say there is a worker in a college cafeteria. He's working in the cafeteria, uses the bathroom, doesn't wash his hands very well, prepares food, a bunch of people eat that food, a bunch of people are going to get hepatitis A or hepatitis E. Okay? B and C are the high-risk viruses. B and C are both viruses that are transmitted through high-risk behaviors, what we call high-risk behaviors. And it's either blood to blood, or like blood to semen, or vaginal fluids. So those viruses are transmitted people who, like IV drug abusers who share needles back and forth, like prostitutes who have unprotected sex with a bunch of different men, homosexual men who have unprotected sex with a bunch of other men. So it's any of the high-risk behaviors. So even if somebody, like, let's say they're like in their 50s or 60s and had like some wild, spring break weekend in college, and they had unprotected sex with a bunch of people that they didn't know, and they had maybe tried IV drugs once, they're at high risk, they need to be screened. So step 1 is we have to prevent it. You absolutely, so if you're working community, if you're working with public health, you got to teach people, 1, how this is prevented, and 2, like how to not get it. Hand washing is super important. Safe sex, like protected sex, not sharing needles. There's a lot of programs now that will go into places where IV drug abusers are known to use drugs, and they will give them clean needles in the hopes that they can prevent hepatitis B and C. Now, one thing, unfortunately for us nurses, we are at high risk for getting, especially B and C. And when I say B and C, I mean B with D, but D is you don't really even have to know about it, but D will never show up without B. So I'm just going to say B and C, and just know that D can tag along with B if it feels like it. So those of us in healthcare are at risk for getting B and C because we take care of patients who have Hep B and C, and we're using needles around them. So if we're taking care of a patient and we stick ourselves with a needle that we've just stuck them with, now we are at risk for getting it. The good news is there's some vaccines now. So back in the day, even like 20, 30 years ago, we didn't have vaccines. Now we have vaccines. So hepatitis B is the Hib vaccination. You'll learn about this when you're in your pediatrics course. So we give this to all the babies now, and you should get a booster before you go to college, and that is a really good preventative measure. Now, people who tend to not have good access and healthcare, are underserved populations, people that don't get good, not prenatal, childhood baby care, that hadn't gotten those vaccines are going to be at high risk. We also have now drugs now that can treat and limit the course of hepatitis C. So with the development of both the vaccines and the new medications have done wonders for helping patients actually do quite well and live quite productive, healthy lives, even though they have hepatitis B and C. Once somebody, and this is true for A and E, once somebody has been infected with these viruses, you can always tell that they have it because we can do blood markers for these different hepatitises. So if you're talking to your patient and they tell you that they're high risk, you need to get some markers, and we can tell where the patient is in the stages of their hepatitis based on their serological markers, whether they are in the active phase, which is a little more scary because they are able to spread it during that time, or if it has been in the past and their body has now developed antibodies for it. So if you are a nurse and you are taking care of a patient who you suspect might have something, even if you don't suspect, even if you're taking care of any patient, if you ever stick yourself with a needle, you go to the health clinic immediately and get a shot of immunoglobulin. Immunoglobulin should be given as soon as you've been exposed. As soon as you've been stuck with that needle, you go get your immunoglobulin shot. Hurts like heck. I did this after I was a nurse for, 2 or 3 years, got stuck by a needle. A guy had one of the hepatitises. Went down to the healthcare clinic, got this big old shot. It feels like a shot of glue in your butt. I couldn't even sit down for days. Nonetheless, it's given right away, and then it will kick in, though it accelerates that immune system because you've got about a 2-week period of incubation. So you need to get this right away because the vaccines are going to take a lot longer. So it's not going to be beneficial if you get stuck and then run get a vaccine. You'll still want to do that, but that's not going to help you getting stuck right away. So you get the immunoglobulin, your antibodies will start developing, and hopefully it will protect it for developing into full-blown hepatitis. And then always, always, always implement your standard precaution. Obviously, we're going to want to, okay, there's my lovely family. Let's try this again. I'm not sure why I did that. There we go. So, I can't remember what I was going to say about that. So the A's and the E's you're going to want to always prevent with good hand washing, making sure if anybody's working in healthcare, food preparation, that they're washing their hands and using good hand washing techniques. Table 49.4 in your book is excellent for this. The non-virals would be things like your patients who overdose on like Tylenol and stuff. Those can sort of cause, it's not really a virus, but it can cause a hepatitis. Just because you've traumatized the liver too much. So sometimes there's non-viral hepatitis. Okay, so it's kind of important to know that there are some different phases of hepatitis, and this is true with all 5 kinds of hepatitis. There is a pre-icteric phase, and this is the incubation phase I was talking about. That's going to last about 2 weeks, and typically people don't have any symptoms here. Then they move into the icteric phase. Icteric is another word for jaundice. So if you see the word icteric, it also means jaundice. Your patient is starting to get yellow. They are also infective during this phase. So when your patient is in the infective stage, they need to be extremely careful to not infect other people because it's during this time that, if they're family members that they live with, people in their same home, they for sure should not be having unprotected sex with anybody because it's during this phase that they are also able to spread the disease. The problem is a lot of people don't actually get icteric. Not everybody that has hepatitis ends up getting jaundice, and so sometimes they don't even know they have symptoms, And it's during this phase that now they can give it to other people, which is why this virus is able to spread so rapidly and so quickly. And then there's the recovering phase. It depends on how bad it gets. Now, not everybody who has hepatitis has the same level of illness. Some people just have general malaise, a little bit of fatigue, where other people are full-blown ascites, hepatic encephalopathy, things like that. Really has a lot to depend on if there's comorbidities, and the other access to healthcare and things like that. So the people who have hepatitis B and C, although we have vaccines for it and treatment for it, those kinds of hepatitis, then the patient will chronically be a carrier for the antigens because of the antibodies, because they have built up the antibodies to the virus, which was the originating antigen. The problem with these is it can lead to cancer. So your patients who have had a history of hepatitis B or C now are at higher risk for developing liver cancers. That's not the case with A and E. A and E can have some of the same liver disorders like I talked about earlier, but they're not they're not at any higher risk for developing hepatic malignancy. A lot of people will become chronic carriers. This is why once somebody's been identified as having hepatitis, it's really important to follow their lab work to find out, are they a chronic carrier of that disease or not. The antibodies, like I said, will be present for a lifetime, and so we can figure out where somebody is in this phase. And the assessment and diagnostic findings in your text really does a good job of explaining this. It was too long to put on here, but I would encourage you to go look at that in chapter 49. Teaching prevention strategies, I would recommend you guys looking at chart 49.9. Immunize your patients. Make sure that you are aware of the difference between active vaccine and immunoglobulin, which is what I just described. Immunoglobulin is it's not specific. It's not like when you give somebody a vaccine, you give them a little dose of the virus that you want their body to build up the antibody to. Immunoglobulin is just really broad. It's a broad way to give a patient very quick immune support, but doesn't have those specific immunoglobulins. Okay, so what do we do? So somebody's got hepatitis now. What do we do? Like I said earlier, we have some really good medications on the market now. These are kind of new, which is giving us some really great ways to treat hepatitis. The best single therapy. You always want to go single therapy because it's easier. By single therapy, I mean one drug, not polypharmacy where there's multiple drugs. It's just a lot easier for the patient to ingest, and it's a lot easier for the patient to take and to remember what pills to take. So the best one we have right now is alpha interferon. Alpha interferon is a biological response modifier. It's very, very effective for the treatment of hepatitis B. But again, your patient one has to identify that they have Hep B, go to the doctor and seek medical attention, have the means and the resources to be able to get the alpha interferon. These are not cheap drugs. So if they don't have health insurance, and as we all know, there's big debate with health coverage right now in America. So there's a lot that goes into this, but this is the best drug that we have. We have some other combination therapies now, and hopefully you've talked about this in your pharmacology class. Hepsra, Epivir, Baraclude, all of these are antiviral agents. A little bit less effective, but sometimes they can still be used if, let's say that a patient is refractory. By that word I mean they're not responding as we wanted them to. So if they're refractory to something like alpha interferon, you can start using some combinations of these drugs. Ribitol is effective. This one, ribitol, ribavirin, is very helpful in improving patients who have Hep C and in patients who continue to relapse. So they'll get a little bit better and then they'll relapse. And this is the nature of hepatitis, is you've got these different phases, and the recovery phase can be long. It can be, a year or more. But then if the patient starts having some health problems, comorbidities or something, the hepatitis can flare back up again, especially in the chronic carriers. Okay, so that's hepatitis. So I guess I'll just keep going because it hasn't been that long. So I'm just going to keep going and tell you about cirrhosis. Cirrhosis is caused, it's not a virus, cirrhosis is caused almost always, well, it used to be almost always, I'm going to say about 80% of the time, and that's me making up that number, I don't know that number for sure, but it's a lot of the time it's caused by drinking. People that drink too much, this is what a normal liver looks like. And a liver with cirrhosis, it gets very blistery. And there is an in-between phase called fatty liver. The fatty liver is people that drink too much. It's very hard on the liver. The liver metabolizes alcohol, and people that drink constantly are constantly putting that liver in a position where it has to metabolize and get rid of alcohol. So people that constantly drink way too much or binge drink start developing fatty liver. At the point of fatty liver, if you can get your patient to stop drinking at that point, the liver can regenerate itself and go back to normal liver. And again, you follow your lab values. When the AST and ALT numbers start going up, you might have a problem. Get an ultrasound or CT scan, find out that liver is getting a little big, they got a fatty liver, and hopefully you get your patient to AA or some kind of other resources to help control their drinking. But at some point there's a state of no return, and when it's flipped over into full-blown cirrhosis, it's the point of no return. The damage is done, you can't fix it. One difference with cirrhosis now is because the obesity epidemic is getting so significant in the United States, now we are seeing a lot of people developing cirrhosis because of obesity. Because remember I told you here's the normal liver, and then you get this fatty liver not because of drinking, but because of too much fat. And so then if that's also not curbed, which is why the bariatric surgeries are helpful, that can also lead to cirrhosis. And cirrhosis then is a dying liver. And so you're going to see all those symptoms that I talked about because the liver is dying. It will lead to high ammonia levels, and because it can't break down that protein anymore. That's going to lead to encephalopathies because it can't break down the protein anymore. So one thing that we can do in our patients who have high ammonia levels, and this is true with your end-stage hepatitis patients too, their ammonia levels get very high, is you can give lactulose or Cefilac. And this is a drug that causes diarrhea. And what happens in that is that it will attach the ammonia to the stool and pushes it out and creates diarrhea. So because diarrhea typically has a lot of ammonia in it, and so sometimes when your patient's developing high ammonia levels in both cirrhosis and hepatitis, that is one way you can get those ammonia levels down, because it's pretty hard to get the ammonia levels down in patients. And the third liver disease that we worry about is liver cancer. So your patients who have had Hep B, Hep C, and cirrhosis can develop liver cancer, a hepatic cellular carcinoma. Colon cancer loves to metastasize to the liver. A lot of cancers like to metastasize to the liver because a lot of stuff filters through the liver because the liver gets rid of toxins. So your patient who has either of these, hepatitis or cirrhosis, can then develop carcinomas, see like this, these big carcinomas here. And so the way that you figure that out is you got to get a biopsy. Remember, I've always told you cannot confirm anything until you get a biopsy. And so if you have to go in and biopsy the patient's liver, they're going to be in the operating room, and they'll lay on their left side or sort of sit up, depends on which way the surgeon wants to do it. They go in, they'll get a little piece of biopsy, and afterwards they'll return the patient to the unit, and you have your patient lay on their right side. That puts pressure on there because remember I told you that liver is very vascular, and you want to make sure that that liver is not going to bleed after the biopsy. So you lay the patient, put a little pillow under there, and lay the patient on that right side to put pressure on there after the biopsy. Then, depending on what they find, like if a patient has end-stage cirrhosis, because the cirrhosis is not a virus, so they're not going to have a virus everywhere. Sometimes your Hep B and C patients who have had severely damaged livers they can go on the transplant list. Now this becomes a bit of an ethical dilemma, because if your patient has killed their liver because of drinking too much, should they get a liver? Should they be on the transplant list to get a liver over somebody who maybe has hepatitis C because they got bad blood? The blood transfusions before 1992 were not screened. So some people that have hepatitis B and C, they got it of no fault of their own. They were given blood that had the viruses in them before it was tested. So now you've got these two people. One person has a dying liver because of, let's say, hepatitis B because they got bad blood, and somebody else needs a new liver because they've got end-stage cirrhosis because they drank too much alcohol. Well, should both of those people be on the same level of the transplant list, or should the person who got the blood, who now has a dying liver, go ahead of the person who quit drinking or kill their liver because of drinking, and had they quit drinking? So these are a lot of big important issues that we talk about in healthcare, and they're very valid questions, deep things to consider. But you can transplant a liver. It's complicated. It's not as easy as the kidneys. They reject more than the kidneys. But like I said earlier, you can do living donor, because they can take a piece of a living donor and then insert it and it will regrow. So complicated. It's kind of a bloody system, or transplant. And then they're on all the anti-rejections, just like we talked about with kidney transplants and cardiac transplants. So okay, I'm going to stop there. That'll be part 2. And then I'm going to teach you about the biliary system, which includes the gallbladder and the pancreas. So that's part 2.